Neonatal jaundice. Lecturer, Professor Ochigbo. Definition: phthisis, yellowish discoloration of the sclera of the eye, mucous membranes, and skin, especially in the newborn. Phthisis due to breakdown of hemoglobin and leads to the formation and accumulation of lipid-soluble, nonpolar bilirubin pigment on the skin. Jaundice is a common problem in the newborn. Observed in the first week in 60% of term infants and 80% of preterm. Poor management of jaundice leads to varying forms of CNS damage. Source of bilirubin. Metabolism of heme. 10 milligrams kg day. 1 gram hemoglobin produces 34 milligrams of bilirubin. 75% from old RBCs released from RES. 25% from ineffective erythropoiesis, myoglobin, cytochromes catalase, peroxidase. Neonatal hyperbilirubinemia. Visible jaundice. Adults, 2 mg% or mg/dl. Newborns, 5 mg% or mg/dl. Up to 50% of all newborns may develop jaundice. Metabolism. Heme biliverdin plus CO plus Fe. Indirect bilirubin. Indirect bilirubin binds to albumin in plasma. Pathological jaundice. Appears within 24 hours of age. Increase off bilirubin greater than 5 milligrams DL day. Increase off 0.5 milligrams DLHR. Serum bilirubin greater than 15 milligrams DL. Unconjugated 10 times a body weight. Jaundice persisting after 8 days in term infants and 14 days in preterms. Signs of underlying illness. Direct bilirubin greater than 2 milligrams DL. Causes. Common causes. Prematurity. Sepsis. ABO incompatibility. G6P deficiency. Ring compatibility. Physiological jaundice. Characteristics. Appears after 24 hours. Healthy infant. Maximum intensity by 4th, 5th day in term and 7th day in preterm. Serum level less than 15 milligrams DL. Clinically not detectable after 14 days. Disappears without any treatment. No hemolysis or underlying metabolic disease. Note: baby should, however, be watched for worsening jaundice. Why does physiological jaundice develop? Increased bilirubin load. Defective uptake from plasma. Defective conjugation. Decreased excretion. Increased adenohepatic circulation. Mechanism. A. Increased production. Increased bilirubin load to the liver due to relatively high red cell mass. Decreased RBC lifespan. Increased ineffective erythropoiesis. Increased turnover of non-hemoglobin heme proteins. Reduced hepatic uptake due to low ligandin. Reduced conjugation due to low activity of UDP enzyme. Ineffective bilirubin excretion. B. Increased enterohepatic recirculation. Increased glucuronidase. Increased bilirubin monoglucuronide. Decreased intestinal bacteria. Decreased intestinal motility and stooling. C. Increased red cell mass. Polycythemia. D. Increased hemolysis. ABO-RH incompatibility. Deficiency of red cell enzymes. G6PD, pyruvate kinase, hexokinase. E. Defective red cell membrane. Spherocytosis. Elliptocytosis. F. Infection. Neonatal septicemia. G. Hemolytic agents. Naphthalene. H. Extravasated blood. Cephalhematoma. IVH. 1. Defective conjugation causes. Crigler-Najjar syndrome. Gilbert syndrome. Hypothyroidism. Breast milk jaundice. Drugs. J. Other factors. Pyloric stenosis. Intestinal obstruction. Down syndrome. Infant soft diabetic mothers. Prematurity. Evaluation of baby with jaundice. Assess clinical condition. Decide whether jaundice is physiological or pathological. History off intestinal obstruction, delayed passage of meconium, color of stool. History off jaundice in other siblings. Look for evidence of kernicterus in deeply jaundiced newborn. Blanched skin with a finger jaundice. Significant when appears at palms or below knees. Color off jaundice, golden yellow or greenish tinge. Transcutaneous bilirubinometer. Bruising, cephalohematoma. Others, organomegaly, anemia,